Good morning, everyone. Yes, I'm happy to get us going, Kathy. Um, I'm Allison Crumpf. I'm the Deputy Commissioner for the Department of Mental Health. And Dr. Levine was going to have the welcome and intro this morning, but the governor needed him for a brief meeting early this morning. So he'll be joining us as soon as he's able. So I thought I would turn my welcome and intro into just a brief note about how much I enjoy working with Dr. Levine, because I've got a co-partner here who happens to be wearing the hat of leader for a public health crisis. And I think my guess is many of you are showing up to this meeting facing a million crises and finding this space to look forward and talk about 2 years from now. And so what I've enjoyed about Dr. Levine, although he will be delayed today, he shows up to our prep meetings. Even with all that he has going on, he's coming to, an hour-long meeting with Kathy and I and talking about a vision for all of this, how he wants the conversations to go, what he thinks could be a future space. And so I don't know if I've shared this, but part of my other hat that I wear in my other world is I'm in this PhD program for leadership and policy studies. So I get to read a lot of leadership books. Some of them not so great, suffering a bit from, say, great white man theory, but others pretty good. And across the board, what I keep reading is that even in a crisis, when you survey folks of what they want from their leaders, vision comes up at the very, very top. And so a lot of them walk through the importance of continuing to strategic plan, even during times of crisis. And with my mental health hat on, I've also recognized that one of the worst things we can do for ourselves is to never give space to think, because we're constantly trying to bat all of this down. And so what Dr. Levine does and what I watch him do, and I'm so grateful for him modeling, is at least carving out small spaces of time to think. And so I found that although it stresses me out to think forward when I've got so many things staring me in the face at 8:30 on these Tuesday mornings, I am grateful for the space and time. And so I just wanted to acknowledge, I know Dr. Levine isn't here to hear this, but for all of you to know that he is making that space, and both of us are incredibly grateful that all of you are as well, because I know it's incredibly difficult. And so the goal here today is to say, thanks for coming. We're all here. We wanted to highlight that it is being recorded today. And so there will be a chance to watch it back. And then also we are going to have the chat open, but we're going to ask that if you are commenting on the chat, if you could keep your comments related to the topic. We're going to be using that, and it'll be part of the recording, and we want to be able to use those comments to add to the conversation and publish that. And so it'd be more useful if it's tied to the topic at hand. We do want to thank our panelists for their time today. We have a great group here today. We are one down due to COVID, which given the statistics, that's not so bad. But we are thinking of Jane from the CCBHC world, who's not able to be here with us today. But we do have other panelists who will be talking to us about 2 different models related to integration. Both the FQHCs and the CCBHCs, which is an acronym we'll walk you through to better understand. After those panelist discussions, we'll be going to the pre-assigned breakout rooms. So if you noticed today that you had some competing meetings on top of this meeting, those are your breakout rooms, and we'll alert you to what those are called, and you can make sure we can find them when it's time. That space will be used to gather questions that you have, because we want to give you a chance to reflect on what you're hearing from the panelists and then come back and ask any additional questions. So it'll be a chance to, in a small group, kind of collate some questions and come back and review those. Dr. Levine and I will be asking the questions when he is back here, and we'll alternate between the 2 models, the FQHC and the CCBHC. So you and your team can choose who answers the questions if you'd like, or just direct them towards a CCBHC or FQHC member. We are going to ask for that everyone avoid using acronyms as much as possible, which is hilarious because I just said CCBHCs about 1,000 times. But if you can do that, we have a lot of folks from the public and in the recordings who will be reviewing this. We want to make sure people know what we're saying. If you could keep your responses fairly brief, we do want everyone to have a chance to share information. And our goal today is to kind of pique people's interest. You won't walk away an expert, but it'll give you a place to go to get more details. And then after today's meeting, we'll send out additional materials that the panelists have provided about the models. We'll also give you more bios on each person. So if you're looking for specific info, you know who to go to. Are there any questions about the agenda today? Okay. And so what we're going to do now is I'm going to ask each of the panelists to introduce themselves, and we'll ask to please tell us your name, title, and organization. And I'm going to start with Mr. Michael Costa.
Good morning, Michael Costa, Chief Executive Officer for Northern Counties Healthcare. We're a federally qualified health center in the Northeast Kingdom with sites in St. Johnsbury, Concord, Danville, Hardwick, Island Pond, Orleans, and an Express Care clinic. And then we in St. Johnsbury. Also, we operate a Medicare certified home health and hospice agency. And I'm joined here today with two other folks from Northern Counties.
Okay. Michael, how about we go to them next?
Great. I'm joined by Chris Town. Chris.
Good morning, everyone. It's nice to be here. My name is Chris Town. I'm the Chief Strategy Officer for Northern Counties Healthcare. I've been here for around 6 years. For a majority of my tenure, I supported our federally qualified health center division directly, as Michael described, but I've been in my current role for about 1.5 years. And in that role, I've also been doing a lot of our COVID response.
Then also we should be joined by Dr. Betsy Fowler, who is our Director of Behavioral Health.
Good morning, everyone. Yes, I am the Director of Behavioral Health at Northern Counties, and I've been with the organization for 15 years, and have been involved in increasing our levels of integration over that time. And I think the whole state has come a long way during this time. So I'm glad to be here. Thank you.
Thank you. I'm going to switch gears over to the CCBHC folks, and we will start with Brett.
Sure. Hi. Good morning, everyone. My name is Brett Beckerson. I am the Director of Policy for the National Council for Mental Wellbeing. We are a national organization that represents community mental health and substance use providers, as well as the associations that represent them. At the National Council, I provide guidance to state policymakers as they begin to envision the CCBHC model and see how it may align with their current systems of care within their state. And I know we have some members here as well.
Oh, do you want to introduce who you have with you?
Well, I have Monica Witt on our team, and I can introduce her because I know she's just here on audio. But Monica leads our work around aligning mental health and substance use care through the CCBHC model with partners such as homeless populations, the justice-involved population, as well as some of our work with children and youth in schools. And so she's our co-pilot as we begin to look at broader systems integration outside of public health.
Great, thanks, Brett. And then we will be going to Christy. Go ahead, Christy.
Good morning, everyone. My name is Christy Everett. I'm the Director of Operations here at the Clara Martin Center. We are the Community Mental Health Center for Orange County and Upper Windsor County. We are implementing the first CCBHC in the state of Vermont. I was the one that actually wrote the grant application to get the CCBHCs here. So we have been implementing this since we got the grant in February of 2021. So trying to sort of build this model here in Orange County and starting to see sort of the outcomes that we've been able to achieve and how this model is really starting to transform care delivery here in Orange County and the potential for integration across both our county and the potential for state mental health services is pretty exciting. So I'm excited to sort of share the model and what might be possible here in Vermont if it expands outside of Orange County.
Thank you. So as you can see, we've got a nice array of folks from big picture to local, and we're really grateful for your time today. So if there's no further questions, I'm just going to jump right in. And my first question to the panelists, and I think maybe we'll start with the Certified Community Behavioral Health Clinic folks, is if you could just briefly describe what a CCBHC model is. And specifically, you know, one thing we thought would be helpful, if you have any stories about a patient or client's experience coming to you for care in that model, how they are assessed, what's different about that, what's different about the payment, is there any differences in assembling and coordinating through teams, treatment teams, and outcomes. Just, that's a lot, but try to paint a picture for us what's different about somebody walking through the doors of a CCBHC versus the current model that we have.
Well, Christy, I can go first, and if you want to build on kind of Vermont's experience with you as a grantee, would that work?
Sure.
Okay.
That's perfect.
So the CCBHC model is a community mental health and substance use care model that provides integrated services for anybody who is within their community. You know, Allison, as you kind of brought up, you know, anybody who walks through the doors, and what's really brilliant about CCBHC, and it could be, some places they're called center because CMS refers to them as centers in some cases. Some places they're called organizations. So the last kind of acronym, you may see it kind of shift a little bit here and there. But you had talked about, you know, what's different about a CCBHC for anybody who walks through their doors. And what's great about a CCBHC is that the door comes to you. So you can be out in the community where somebody's living and be able to receive the payment rate that you would receive if they were inside of your office, right? So it is providing the opportunity to not just elevate care delivery, right? So ensuring that high quality, evidence-based mental health care is being provided by those within the facility, but also outside of the facility. It ensures there's quality reporting. So we're not just tracking, you know, the number of patients we're seeing or types of care we're delivering, but actually are people getting better? And all of that is supported by a PPS, or a prospective payment system, that's very similar to an FQHC. But as you're establishing the model, you look forward to see, what do we need to do? What are the current gaps in our system, and what's that going to cost? And so for somebody coming into a CCBHC, for a provider coming into a CCBHC for workforce, they're going to be compensated at a rate to solve the problems that are ahead of them. They're going to be able to deliver and create a structure that looks at really what needs to be done from either those who are underserved or for the different kind of things that need to be solved either systematically or at a more direct service level. But I don't know, Christy, if you want to share some more of your experience at Claire Martin.
Yeah, I think it's been a really fascinating experience for us, really starting to take a look at focusing on true patient-centered treatment when someone comes to us, and really starting to take a look at what are the services that this person truly needs, and not having to sort of be beholden to the structures that are currently in place and having to have someone sort of qualify to be able to provide a service to them based on whether they're eligible for that type of service. Now, if they need a service, we can provide it to them. So for example, like we have a huge population of folks who are elderly who they could only, if they have Medicare, they could only be provided therapy services by someone who has like an LICSW. Now through CCBHC, we can actually provide them services by someone who doesn't necessarily need to have the LICSW degree and license. They can actually be provided therapy services by someone who has a different degree. So that's opened up access for those type of services and reduce some of those barriers to care. And CCBHC has allowed that to happen. And we can really sort of identify what services people need and provide those to them. That's been a huge option for us that CCBHC has allowed. Targeted case management for people. So before, people really needed to be eligible for case management services. Now we can provide it across the board. If someone needs that, we can provide that service to them. And it really is, as Brett talks about, sort of that capacity. We have that capacity now under CCBHC to provide that to people. And it's really just sort of expanded that sort of holistic care that we can provide to folks. So it really has been sort of business changing and philosophy changing for the organization.
Thank you. I can't help but a follow-up question popped into my head. As some of you may know, the Department of Mental Health, in partnership with DEVA, engaged in payment reform starting a few years ago. And the goal was to get to some of what you just described. And so one of the examples was not having to wait for folks to be eligible for certain services and being able to provide things like targeted case management. And so, for example, you can build a case rate if someone's in outpatient services for case management. But what you can't do, which I heard there, is allow somebody without a licensed clinical social work degree serve someone with Medicare. And I was just curious, I don't know if Brett, I don't know if you have that depth of you work in that area of policy, Brett, but could you explain what's different about CCBHCs that allows a difference in license to serve a Medicare population?
I'm sorry, just for Medicare or for Medicaid?
These were what I heard Christy say is these are Medicare clients, right, Christy?
Yeah, so based on sort of what the need is, we can actually have them see a therapist, regardless of sort of what their credentials are, and get them started into services.
So the CCBHC model is a Medicaid model, and where you may see some opportunities with the grant is that the grant provides a lot more flexibility. Now, when it comes to the actual model itself, that's something that's described and defined by the state. So the federal government creates a foundation